On behalf of the Academy of Osseointegration and the Dental Guys podcast, I'm Wes, the Dental Guy.
And I'm John, the Dental Guy.
Well, we're here, John, again, live broadcasting to you, bringing the greatest minds and researchers in all of dentistry so that people can take complex subjects and understand more about them, decide what's good for their patients and their practice, and really take their dentistry to the next level. That's what we've been all about. I know that's what the Academy's all about. Evidence-based dentistry. And John, tell us a little about who we have us today.
Yeah, so we're excited to get to really kick off this time during welcome reception at the meeting, which is a great time to be talking. This is really, I think, why many people come to these meetings. It's for the time at the end after we've seen some great lectures to be able to actually talk about what we've learned and how does this apply. And we have two excellent clinicians and researchers, and Dr. Dennis Tarnow and Dr. Howie Gluckman here. Thanks for being with us. Really appreciate you guys being here.
Thanks.
Thank you.
Thanks for having us.
We are we've been kind of planning this show for a while because we know that there's some great discussion to be had about one of the most interesting topics that has been discussed for years and years, which is how to manage the immediate extraction socket with an implant. What do we do once the tooth has been removed, or do we remove the whole tooth? And what do we do with the gap? And what do we do? How do we manage the soft tissue? And our goal, of course, is to minimize changes. And we know both of you have been heavily involved for years and years in this area of research and clinic. So I think maybe the easiest way to kind of get people calibrated to what we're going to talk about is most of you watching this or listening know when we mention the word dual zone technique and socket shield or partial extraction therapy, know what we're talking about. But for those of you who don't, let's maybe quickly summarize what that means. And Wes, I'll let you do the quick summary, and then we're going to ask the questions we think everyone wants to have the answers to.
Well, let's start with dual zone. First of all, the tooth is extracted, and once the implant is in place, if you place it properly, okay, there should be quite a bit of a gap between the implant and the bone and soft tissue. And zone 1 grafting, John, would be a grafted allograft, all right, up to the top of bone. And then the second zone is the soft tissue zone, but we're grafting that with bone. And as Dr. Tarnow published, that zone of grafting does help to thicken soft tissue, okay, over time if it's managed volumetrically. And then on the other side of the table, we have a technique where most of the tooth is really not extracted, but the tooth has been shaped, and there's a remaining shape of the tooth that's left as a shield per se, to shield volumetric change from muscle.
Yeah, to try to maintain the bundle bone.
That's right.
And so as we talk about these techniques, many of the questions that we start to have are, well, which technique works the best? Which is the most validated? And then that's everybody wants to know what's the best, right? But maybe it's what's the most appropriate for the situation or the case. And then also we want to talk a little bit about, what's the most teachable and the most achievable for most clinicians. And so let's talk about that. Maybe we start with you, Dr. Gluckman. What do you talk about the technique comparison and, your thoughts on what works where and when, and how do we make some of these decisions? And Dr. Tarnow, we'd love to hear the same from you.
Sure.
I think I will start by saying that my journey started with dual zone therapy many years ago. And I think one of the problems that I had with the dual zone therapy is that over the long term, things started to collapse on me. And I didn't get things as well as I wanted to. And socket shield answered some of those questions for me. And it is not a simple technique. It is certainly a reproducible technique, and it certainly is a teachable technique. But it started to give me something which I feel was a little bit more biological than other techniques because of the fact that this piece of tooth prevented the bundle bone from disappearing in any way or in any shape or form, whether it was thin, whether it was thick. But saying all that, there's still a time and a place for everything. And I think each technique has to be, you have to choose each technique specifically. There's certain parameters that the socket shield requires, and you need to make sure that you follow the right guidelines to do them. If that doesn't work, dual zone therapy, for me, with a soft tissue graft would be my go-to. But I think it's a horses for courses kind of approach that one has to take. And to coin a phrase, I think it's each technique is something that it just gives you another option. If all you have is a hammer, then everything looks like a nail, and you want to have multiple tools in your armamentarium to make sure that you can give the patient the best for that for their thing.
So on the counterpoint, Dr. Tarnow, do we need, as clinicians, the armamentarium of the socket shield to achieve the therapy we need for immediate extraction, immediate placement, or is dual zone enough?
Well, I've been using dual zone now for about, I guess, 9 to 10 years in a private practice. And initially we weren't doing immediates because we weren't sure about the healing of the gap. And we'll talk about the healing of the gap with either technique. I think that's important, and what the graft does or not does and the gap size. But that was a controversy because people said that if you have a gap distance between the bone and the implant of initially greater than 1.5 to 2 millimeters, almost everybody said the same thing. From research as far back as 1988 has shown us on animals. Akimoto and Becker did this also. So there's about 6 or 7 articles that held me back from doing immediate sockets because what happens if I had a 2 millimeter gap? Then I would have a fibrous seam next to the implant. In other words, I wouldn't have, without a socket shield. I'm talking about if I had a buccal bone, but I didn't leave a piece of tooth in there, I would have a gap sometimes greater than 1.5 or 1 millimeter. And so I didn't want to have a fibrous seam between the implant and my buccal bone. So the concept being that if I had a fibrous seam, I could get future peri-implantitis and it could unzip on me right down the front. It wasn't bone up against the front of my implant. And then I realized when I went back into that literature, I realized there was a flaw to that research. They all did one thing thinking it was okay. They put the implants in with the different size gaps, and then they put the flap over the top. And they did primary closure without a membrane over it. So they put, here's the implant with a trough around it or a gap. They would put the flap of the animal, they put it over the top. And then the fibrous tissue from the flap would be able to go right down. And that was faster than the bone coming across the gap.
Mm-hmm.
And that's why all the research was valid, but that's if you do primary closure. If you do secondary intention healing, which is what we do, no flap, leave the tissue exactly where it is. When you open it up, then you have a gap distance, and therefore the gap doesn't matter. The gap size doesn't matter. Bone will fill into any gap size, no matter what size it is. And that's a misnomer that people still think, 1.5 millimeters, you got to worry about, you don't want to get too large. That's ridiculous. We've learned that is incorrect, and that's only if you pull a flap over the top. So that's what allowed us to do. And that was about 10 years ago. And we realized that we were getting, and we published on this with one of our articles about 2014, that if we supported the tissue with the temporary, which is what we all will do, and if we filled the bone, not just up to the gap, but filled it supercrestally, the so-called dual zone, meaning the soft tissue zone, we found that our tissue was thicker when we had the healing, and we documented that and published on that. We actually measured those differences, and it was as much as 50% thicker when we did the grafting all the way to the top of the free gingiva, and then put the temporary on at the same time. And that was our best results. And we published on that about 4 or 5 years ago. And so it's been a mainstay, and we haven't come back to hurt us. If something hurt us, we're in the middle of Manhattan, and we're in a pretty private, high-level private practice. And if it hurt us cosmetically, we wouldn't be doing it. If it hurt us 5 years later, we certainly wouldn't be doing it. So we haven't found, by placing the implant to the palate, filling the gap, and bringing it up to the top, that for us has been a real mainstay for our private practice, and it's been held up all these years.
So the feeling being that maybe that's so where I know we talked about, we had in your lecture this morning, you were showing some cases, and one that you showed that was maybe a little bit more extreme challenge was adjacent implants. For instance, an existing implant was there in a number 7 location. Patient was going to lose number 8. And, the question was, well, is dual zone enough for a case like that, for instance? Now that maybe that's an extreme situation.
I'm not sure that it is extreme. I think it's the reality, and I think it's something that we have to prepare for right now. And I think that's where for me, where things start to diverge, because there are certain times. One of the key factors with dual zone is that your buccopalatal dimension has to be wide enough to allow the jump gap size that you require to pack bone, so that the biology can take care of that bone and create new bone. There are a lot of cases where you don't have the buccopalatal dimension. In those cases, your implant is going to end up closer to the bundle bone that it would be, meaning that the chances that you're going to have no buccal bone over the implant is fairly high. The second thing, as you mentioned now, is that when one has a second implant, and Dennis, you'll know better than anybody else, being so well published on that, the minute you put 2 implants next to each other, that bone is going to collapse. And interestingly enough, there's a new publication coming out from Joseph Kahn's group where they actually measured implants next to each other and showed the maintenance of papillae with what I was showing this morning in the lecture, where for the first time we are getting phenomenal interproximal bone, and it's staying absolutely stable. It's not resorbing at all. And even when you have an old implant next to a new implant with a socket shield, it doesn't need to be two socket shields together. So I think with that kind of situation, if one can utilize that kind of forum, does it mean you should only use it for adjacent implants, etc.? Yes, if that's the way you want to work and dual zone is easier for you, I think you must use whatever works for you. I think that's important for us to say. I don't think we must push anything in any direction. For me, though, I think I want to make sure that should I have an implant next door, I have the option of maintaining that interproximal bone. And certainly, I don't see another technique that I can use that allows me to keep that interproximal bone the way socket shield does. And that's where I think maybe it really is something that's exceptional compared to some of the other techniques.
You know, we're
Let
talking
me just
about
comment on that.
Yeah.
Remember, they've got to differentiate, and I don't disagree with what Howard just said for interproximal. So let's differentiate between interproximal and midfacial. I was talking strictly about midfacial when I had my discussion with you just now, that buccal gap. And interproximal, I know Joe's worked really well, and he's done a great job with this. And yes, he came out with, I think, almost 2013 using the interproximal support of socket shield, leaving it alone interproximally so it would stick out. What we're missing when we have two implants next to each other, as you know, is the supracrestal biologic width on something, preferably the tooth if it's healthy. So what Howard's recommending and what Joe was talking about, Joe Kahn, correctly is talking about let's keep the tooth in the interproximal area so that we have some fibers, some gingival fibers, which is supracrestal, there to support the papilla. And I don't disagree with that. And I think we got to do more research on it. But I think that Joe's on the right track and you're on the right track by saying let's at least, and you only need it on one tooth. You don't need it on both teeth. Just like a single tooth implant. If you have one tooth that's healthy and you put an implant next to it, the supracrestal fibers support the papilla from the natural tooth, because the biologic width on the natural tooth is supracrestal. And that's what's supporting the tissue. That's why everybody loves to show you single tooth implants. When you get to two, like Howard brings up, there's no question it would be great to leave a piece of it there, or a C shape, in the remaining piece if you leave the buccal, but you leave the interproximal piece also. Like when you, and this is just technique. Some people leave just the shield interproximally, but if you can leave the buccal and interproximal, then just leave more around, and you can accomplish that. So I think that's probably one of the major places where I think socket shield will really help is interproximal between two implants. I don't disagree with that at all. I agree with you 100% on that.
And I think this is amazing stuff, because here's what you're doing is you're rewriting what we are using in our clinics today, which is how much papilla can we generate right now. And based on your research, between an implant and a tooth, it's about 6.75 millimeters mean. And we know implant to implant, based on research published, it's much less than that, a millimeter and a half less than that in the 5 range. And that's mean. That means we could get less, we could get more based on phenotype and based on like the procedure that's done. And if we're going to rewrite Frank Spear's article on Pontics versus implants, I think that's where it comes into the next question, John, is how we talked a little bit about this in the pre-show per se, about the teachability of each of these techniques. And Dr. Gluckman, you said that in one of your articles regarding PET a few years back. I say a few years, but a few years was 2020, and it seems like I blinked and 2020, 2021 went by.
That's right.
But a few years back, you said at the end of the article that PET is a technique that is reserved for the right hands and at the highest level in settings where it needs to be researched, refined, and redesigned. Is it ready to be taught in a systemized way so that we can really get this out to the masses as a thing that can be repeatedly done consistently and predictability wise?
I think the simple answer to that is yes. There's no doubt about it. I think we have got to a stage, and that publication specifically was a publication where we had deconstructed the technique to such a degree that we could make it a reproducible technique. I really believe that, and I think it's just even people might disagree. I strongly believe it. Having taught it luckily enough, in many countries around the world, and having the feedback that I'm getting from people who have done a few techniques. And I think this is a key thing to remember, is that often we will try a technique. You'll read a technique, you'll try a technique, or you'll see a technique, and you'll fail 3 or 4 times before you start to get it right. Those are techniques that are not reproducible. There's something wrong either in the data or in what we're being taught. If you can pick up a technique whereby you can try it the first, second, third time, and you get the same results that I'm getting, that's a truly reproducible technique. And I do believe that socket shield is one of those techniques. We had to deconstruct, we had to think about how we teach it, and teaching it over the years has allowed me to deconstruct in such a way that can allow people to do it. There's no doubt, though, that people need to be trained. And, you know, a lot of people are picking up the technique. They're not even reading the publications. They're kind of reading the abstract and like, oh, that looks good. Look at the pictures, you know, see one, do one.
That's dangerous.
And that's dangerous, you know what I mean? And I think I don't subscribe to that at all. And I think it's like anything else. Go and get trained. There's lots of people who are now doing the training and are able to train you. And it's certainly something that you need to do. And the second thing is you need to have the right equipment. You need to have the right instruments, because if you're just going to use what you have and then you're going to try it, you are going to struggle. But by the same token, remember, sorry, Dennis,
go ahead.
Remember one thing, that when you started dentistry, it took you 3 hours to get through the enamel on your first amalgam. Okay. Everything, and the more you did it, the better you became.
It takes me 5 now. But I do it very carefully. I think one of the important things to still talk about, technique is obviously a major piece, and the degree of difficulty of any technique and reproducibility. But the wound healing between the gap, I think we should go back to that. I think there's my biggest concern, if I have one, of doing it, besides teaching it and all that. That's there. If it's good, you're going to teach it, and we are. But the gap distance and what's up against the implant with the socket shield. What gap distance allows bone to fill in front of your implant versus cementum and potentially fibrous tissue? And what happens if the implant is touching it? Like you said, even with a minimum gap that you can't put a bone graft in, which is rare, but it might be. What happens if you leave a piece of tooth there? It's even smaller. I'm not up against the buccal plate, but you could be up against the root shield. So by putting the implant right against it, then like Hertzler's article and some of yours have shown, you don't even have anything in there. You're right up against the threads of the implant, or right up against the root fragment. Now, will that come back to hurt you in 5 years or 10 years? I don't know. What if you have cementum up in the front of the implant instead of bone? Because if you have a small distance, it's going to fill with cementum. If you have a bigger distance, you'll have bone and cementum. See, the people don't realize the wound healing. It's really a wound healing discussion. Can I take about 2 minutes here?
Yeah, sure.
This is critical. People don't get this because they don't understand what do you get cementum there? Where's the cementum? How come you don't get it? Or something? Okay. When you have, if you take a tooth out, any socket, if this is the socket, I don't know if this shows, if you got this socket, and that's your socket, if all the walls are there, and that's all we're talking about, when all the walls are there, bone will fill into the socket, and it comes from the sides, and the epithelium and connective tissue at the top are the closest cells that could come down, but they don't come down because the cells from the bone coming out of the granulation tissue pre-coated to form bone comes out and fills up the clot, replaces the clot. And so a typical extraction socket fills with bone. Now, if you put an implant in, which is what we're doing with either technique, we just put an implant in, it's really the same wound healing, but with an implant stuck in the middle. That's why gap distance doesn't matter, as long as they keep the epithelium and fibrous tissue at the edge. It will be blocked. It can't come across because the granulation tissue has to support the blood supply across it. Okay, now if you leave a piece of root in there, which is what happens with the socket shield, you have another cell that can fill in the area. And instead of having 3 cell types, meaning bone filling the sides, or epithelium or connective tissue from the top, which is not going to move because it's at the top. It can't come across because you've got to wait for blood supply. The clot can't hold it. But if you put a piece of tooth in there and leave that in there, like in here, if that's a piece of tooth, if this is a piece of tooth that you left in there, you don't mind if I get this wet, do you?
We got plenty.
You got more of those.
Okay.
Where that came from.
And you can see it on camera too.
Okay.
I got more membrane too. So.
It's called the dental guys.
Yeah, that's right.
So if you now you have another cell that can fill into this area. And what is it? You have the periodontal ligament the leftover piece of root that you cut, wherever it is, has ligament at the little 1/4 millimeter space, has a ligament. Ligament is fast growing, and ligament is faster than bone. Ligament is within 7 days that'll fill up the gap. So what happens is that the cementum, cementum comes from this ligament cells, and this ligament comes around the back end, and will cover the back of the root shield. So that's what's on the back side. Bone is slow. Bone is the slowest one out of the two, and that way it doesn't get to the back of this. If you got bone touching the root shape first, it's good though. You want to know why? If bone touched it first, you get ankylosis, and you get resorption of that piece of root shield. So it's good that this is almost the body's protective mechanism of cementogenesis coming around the back and preventing the bone from causing resorption. That's good. But at the same time, if you have a close distance, here's the implant. If you have a close distance to that, you might not have any bone. You'll have cementum at best right between it. More distance, which is great, then you get cementum on the back of your root, but your bone can have the time to come across with a bigger gap. And so what's up against the implant is still open to discussion. I think Howard might agree with me on that. And in terms of, it depends on how, I ask you this, what's your ideal gap distance? Tell me that research that shows that what's your ideal gap distance and what's been proven that is shown when you get bone on the front of the implant instead of like Marcus has shown fibrous tissue or connective tissue.
Yeah, you've got a few minutes to kind of counterpoint that. I think you're showing beveling now, and you mentioned some dimension there of a 0.5 millimeter in some situations. And basically what we're talking about is blood supply.
Well, I think the interesting thing is that where I would disagree with Dennis is that I understand the argument, but the interesting part is that the histology that we have, both animal and human, don't show that. They don't show any cementum. They're showing only bone formation, and they're showing ankylosis. And even the cases where there are, where we've got the inadvertent socket shields, I think there's 2 or 3 articles of inadvertent socket shields. All of them are showing ankylosis and integration. So,
the implant's integrating. That's not what I'm talking about.
No,
I'm
the
talking about
implant's
what's up against the implant.
And if you look at the tooth interface, you've got ankylosis. With regards to the distance, what was interesting was that Hertzler and Danny Baumer's articles were the 2 animal histologies. One they used emdogain, the other one they did not use emdogain. When they used emdogain, that's when they got cementum formation. Was because of the use of emdogain. The minute they changed and they stopped using emdogain, then they only got bone. With regards to the width, you can see from the histology where they've sectioned the root that the tooth itself, the implant itself, was in contact with the root. So there wasn't a big jump gap. It was in contact. You can actually see
the threads were touching.
The threads were touching. That's right. And they actually resorbed away. And where it resorbed, you could actually see bone had filled in on that. If you look at the human histology, which comes from Greece, they show exactly the same thing where you've got the part touching. Now, the research that we've done and the research that's coming, and we've got some new prospective studies which are in working, where we're starting to look at all those factors that you mentioned, because I totally agree with you. They're so important that we cover all the bases on all of that, so we can tick the boxes and make sure that there's no ambiguity in what we're talking about. The reason that we are saying pull the implant away from the root is not for the reason that we are worried that bone is not going to form inside there. What it does do, it allows us to put bone in a dual zone therapy style, number one, which we agree will then help to stabilize the clot, make sure that you don't get soft tissue infiltration. And the second thing that's very important is that we're actually trying to reduce the internal shield exposure at the top, because by moving the shield, the implant away from the shield, you've got much more space for soft tissue to cover the occlusal portion of the shield, which will then reduce the complication, which our study, 128 case study in Journal of Clinical Implant Research, showed was the biggest complication that we had. Right. So that was the rationale for that.
Let's just have to stop one thing. The bone up against the implant has nothing to do with putting a bone graft in. That's a big misnomer around the world today. And people think that if I put a bone graft in and stick it in real hard to any gap, even with the dual zone, they think that between the bone and the implant, you stick the graft in there. That graft does not change what's up against the implant. It's as if you still have a clot. It just has particles in it. That graft is strictly to prevent, just like the shield does, collapse when the buccal bone does go through modification or change, remodeling from the extraction. that it prevents the collapse in facially of the ridge. So that's the graft is to keep space. It is not to change what's up against the implant. This is the biggest misnomer out there. In fact, if you look at all histology with the graft in place, every one of them is without shield or no shield. The graft, as hard as you might pack it into the gap, like a dual zone or anything else, the bone, after you see the healing, is never touching the implant after healing. The new bone comes in with granulation tissue from the side, and it pushes the graft particles all over the place, and they tumble them over inside the clot, and the bone graft actually almost gets in the way, but they just keep tumbling, and up against the implant you got the bone or marrow, but you never touches the particles are never touching the implant after healing. It's one of the most amazing things with wound healing, but that's what happens.
Both of these techniques are designed to do some type of custom tissue former design with subcritical contouring, and both techniques utilize either immediate temporization in some way.
Sure.
Because these are, exactly what we're trying to do is we're trying to stop, right, this volume change. And I think you both have explained it amazingly.
Yeah.
And there's more to learn, right?
I know.
There's more to learn.
I know. I wish we had more time because there's still some great questions that I think we get about how different implant designs even can be used to influence both of the way these techniques work. Even the, talking about how much gap distance do we want to have in order to maximize the ability to place bone into the gap? Does
the implant type matter, John? I mean, we didn't really get into that.
That's.
I got like 59 seconds left.
I know.
Here.
I mean, maybe can we get a quick take on that? Do we think that the implant design matters?
As long as you have some gap, especially with the shield, it really will matter. As long as you have some gap. Without the gap, without the shield, and you just do the dual zone, I think the more gap you have, the more zone of bone on the front can heal. So a coax implant or just one place to the palate. I'll go on record as saying this though, and we need to look at this. I don't know if I mentioned this to you, but I think that the place for making sure that you do a socket shield, okay, obviously I mostly don't do them, but I do them. I have done them, of course, in my office. But where is the ideal place for it is where the tooth that you're going to take out and you see the x-ray and you probe it, it's in intact buccal tissue, but the bone is halfway up the tooth, like a prominent cuspid or a prominent central. And you have a dehiscence defect right there of bone. But you have attachment. You have beautiful cementum on there and beautiful ligament. But by taking it out, by taking that tooth out, I'll now have a type 2 defect. I don't have a buccal plate. Why not that's an ideal place for socket shield. Leave it in, and that way the buccal bone there's no buccal bone there to begin with, but the whole shape of the tissue won't change. It's probably one of the most ideal places to show that you might want to do it. What do you think about that, Howard?
I think I understand where you're going with that. Up until now, we have totally contraindicated that as an option. I see we're out of time, so I'll be very quick.
Real quick,
we've totally called that a contraindication, and we've only dealt with type 1 sockets. But I think one could modify the technique where you extend the shield where bone is more interproximally than what you're saying. But one of the reasons why we didn't, to finish off quickly, was that if you do that and there's not enough bone, you could get a loose shield. And if you get a loose shield, then you could get infection and it has to come out. But I think it's great what you say. If we extend it, it might be an option.
Right. Extend it apically and down, as long as you get the apex out.
I love the concept.
Right.
That
way you never create a type 2 defect. It's
right.
Even though it's sitting there, it's healthy, and the root is healthy, and that's what I mean.
Wow. Well, this has been an excellent conversation. Thank you guys both again for bringing your insight and having a great spirited discussion about pros and cons and what might work when and where and how. And it's been fun. So thank you guys very much.
Yeah, Dr. Tarnow, Dr. Gluckman, thank you so much.
Absolutely.
Thank you for being on.
So wow, Wes.
Okay, so John, would you at this point feel comfortable in saying this is the technique I want to use on my patient? Like Dr. Tarnow says, do what you would do on yourself. If you lost, if you like, I punch you in the face right now and I knock out number 8. I don't knock it out. I just break it off, shear it off at the gum line. Right? If I shear it off at the gum line, what do you want me to do on you if I'm your surgeon?
Well, I think that here's the question that maybe the answer that I would give based on what I just heard is that we know that these techniques can both be successful if we have everything right with partial extraction therapy it sounds like there's some potential there.
Well, if you had
No
the right
question.
clinician, you
But-
wouldn't let me do it
but
on you, but you
That's
let
what I was
Dr.
going to say.
Gluckman.
But I don't know if I'd let you do it on me. Dr. Gluckman, sure, all day long. But I think
Right.
that's what one of the things I'm taking from this is, and we didn't even talk a whole lot about but where to go get trained. If Dr. Gluckman trains you and you've got a lot of experience, maybe that becomes the go-to in certain situations.
How about
but
even better?
how
Let's put Dr. Gluckman and Dr. Tarnow at the table.
Okay, now I see
John,
where you're going
you're
with
laying
this.
there,
Oh man,
and then they're making the decision.
this is like asking someone what implant they would put in on their significant other, right?
That's
And no
right.
one wants to answer the question
Why
because
do
they
you-
don't want any of these companies to, blow dart them or something if they say the wrong thing. I think what I could say there is that if all things being equal, what I'm hearing is done at the highest level, both techniques can be very successful.
I think there's something to be said, especially Ponics versus implants. Like what I heard both of them say is that when we have an adjacent implant now, right now I'm considering cantilever, and
Right.
because of that papilla that I can generate, off of on a Ponic,
Right.
right? And it's really more predictable in some aspects, and now I'm hearing that maybe we need to consider partial extraction therapy instead of Ponics.
Yes,
Right?
that's something
That's
that
the-
I think is making us think differently.
Oh man!
So
So John, one of my favorite things to talk about is ridge augmentation, and because the question comes up all the time, do we place zygomatics, right, in the maxilla, right?
short implants.
or do we place short implants, or in the lower? What type of ridge augmentation are we doing in the posterior?
Yeah, is vertical augmentation predictable in the mandible?
Do you use angled implants, John?
Right. So
Right.
we figured we might want to bring someone on the show that could answer some of those questions. So here he is. And Dr. Buckley, thank you so much
Welcome
for
to the
being with
show.
us. Welcome.
Oh, thank you for having me. It's a pleasure to be here.
Yeah, we're excited to get to talk to you about this topic that, Wes, I mean, we've discussed, we've looked at a lot of the things you've published, we've heard from you multiple times at this meeting and others, and we're excited to talk about what's possible today. Obviously, in the last few years, we have seen the advent of sort of the short implant era, as it were.
Well,
and
Mish said, and a couple years ago, maybe at the last meeting, he said, you know what? When I consider grafting, I first look to short implants.
Yeah, and that was a big change, we thought, as we started to hear some of the people that were big, graft people, quote unquote, who started to say, I'm actually looking more at short implants. But what that didn't change our questions as to what works with augmentation. So let's talk about what are some of the things that you feel like today you're most excited about that are changing, whether it be techniques, materials that are changing the way we look at the ridge augmentation world?
Oh, that's a great question. I think that there's a lot of really exciting things in the world of ridge augmentation. I think that when you bring up short implants, grafting versus augmentation, everything we look at, we always have to weigh kind of the risk-benefit ratio. And in terms of when we weigh the risk of augmentations versus short implants, obviously in some areas short implants is better. Now, one of the areas, conversely, when we look at augmentation, one of the areas that I'm very excited about with augmentation is the reconstruction of the anterior aesthetic zone. So when we look at sites that have, especially now with some, implants are very successful, but sometimes implants do fail. And when they do fail, they sometimes can cause, especially across multiple segments, a severe vertical defect. And so in the anterior aesthetic zone, we have a lot of bone loss in the vertical area. There are a lot of exciting areas and how to regenerate that and to reconstruct it so that hopefully we may be able to give patients that are missing these defects natural looking teeth without having to use pink porcelain and reconstruct natural aesthetics. So that's one of the areas I think I feel most passionate about.
So talk about that. Talk about some of the, we've seen over the years so many ways to do this, right? We've seen particulate grafting, and we've seen mesh, and we've seen blocks, and we've seen milled blocks, and we've seen everything, distraction, and so what's happening now? What are some of the things that you're going to and changing techniques or approaches? What should we be doing today?
So John, that's a great question. I think that when we look at augmentation in the aesthetic zone, we're talking about very delicate. We're really dealing with, 0.5 millimeter to 1 millimeter. You can do a significant augmentation in the aesthetic zone. Let's say you have somebody who has a 10, 15 millimeter defect, and you augment down to, let's say 10 millimeters, you augment down to 8 millimeters, and you miss it by 2 millimeters. You're going to use pink porcelain.
Right.
And so a lot of times, somebody said that if you're going to have to use a little bit of pink, why not use a lot of pink?
Right, get it out of the transition zone completely.
Why not spare the augmentation? So you brought up a very interesting observation. You said that there's a lot of techniques. You see a lot of different exciting techniques, sausage technique. You see distraction. You see, mesh, custom mesh. In the field of augmentation, when we see so many different techniques, if you were to go to a neurosurgeon and you say, hey, I've got a brain tumor, and he tells you, I've got 5 different ways to treat that tumor, you'd be really concerned, right?
Well, this is what I'm talking about. Like, I think you're in our wheelhouse, because this confounds our mind, is how medicine has standardized certain procedures. Are we missing the standards?
No, I think that the augmentation works. So we have a number of vehicles, and we can get in a little more detail about some of the details on some of these, how these defects can be corrected. But these are all just vehicles. They all work. But the problem why there's so many different techniques is that they all have problems. When you're talking about vertical augmentation, especially today with the popularity of the use of biomaterial, you have to remember that biomaterial, we call it a bone graft, but really it's just dead stuff. Biomaterial, xenograft, allograft, alloplast, all of those are essentially biomaterials, dead particles. When you put a dead particle into a site that does not make bone, it is not going to make bone. It's going to behave as a foreign body. It's no different than if I were to put some biomaterial, I cut a little incision in your muscle, calf muscle, and put it there. The wound will open up and invite it to leave. It's going to fail. So when we look at augmentation, in terms of techniques and protocols and this, you always have to look at osteogenic potential. What is the ability of that site to make bone? Now, there are sites, I think that in the field of implants and augmentation, we oversimplify everything. We make everything, the world, too black and white. This is a horizontal defect, I do this. This is a vertical defect, I do that. The world, we live in a gray world. We don't live in a black and white world. So some defects and some patients make bone. The little, the strong, young 18-year-old wrestler athlete, he's got a lot of muscle, he's got exostosis, he makes bone. You can do anything on him, he's going to make bone. You got the 75-year-old little old lady with osteoporosis who has no bone making ability. She's on bisphosphonate. She's got a little diabetes. You throw the kitchen sink on her, you're not going to make bone. So we live in a gray world. And so we have to, in the future, we'll be able to identify some of these patients. Now, we do have techniques to be able to make bone and increase osteogenic potential on some of these patients. But we just have to be able to, there's no set protocols. So going back to osteogenic potential, once we identify patients that have, and sites that have osteogenic potential, then you ask the question, what is the technique that I should use to increase the osteogenic potential? So is this a technique that I can use biomaterial? Is this a technique that I should add some type of growth factors to increase osteogenic potential? Is this a technique where I need to increase the number of cells, transplant cells, to increase the number of cells and include some type of factors to induce those cells to grow? So I think that bone augmentation, especially when you're talking about these significant defects, involves a very tailored and very specific treatment for those patients. It's not a one-size-fit-all, and it will never be a one-size-fit-all.
So the biologics have been an interesting discussion over the years. It seems like when we saw the advent of, say, BMP, it was miracle grow for bone. We were going to do, it was going to do everything for us. And then there were some publications where, it did some things for us, but then it had some limitations as well. where do we stand now in the world of biologics, and how are you using those in your world? And, what do you think the research is kind of heading us toward as far as the use of that compared to where we were in the last few years?
So, with BMP, I think that it's been one of the game changers, I believe, in the field of regenerative medicine. There are many, and I was fortunate to be one of the first people to use BMP early on when it first came out. When I was, when we were working at USC County Hospital, it was free for us to just pick it off the shelf.
Free.
Free. I mean, these were
stuff.
at that time, 20 years ago,
Yeah.
these were like $5,000 packages.
Yeah,
We
right.
were just able to pick it up, and so. I was fortunate to be able to use it. Now, there are many clinicians across the world in many countries, many modern countries, that do not have access to this. So I was able to use that. I would say that it's been a game changer in many practices. How? Well, in the old days, we would have to use either if we have a site that's not osteogenic, it doesn't make bone, we would have to harvest bone. And if we have a significant defect, sometimes we have to go outside the mouth, like the iliac crest or the tibia, to harvest bone. The availability of BMP has eliminated the prospect of me having to go to the hip. I haven't had to open a hip. I was speaking at the Osteoscience Foundation last weekend with Bob Marks, and who's one of the pioneers at augmentation, and he said the same thing.
Eliminated that need.
Eliminated. And if you talk to some orthopedic surgeons, you'll find that in some areas of orthopedics, it has done the same thing. So I work at USC, so we do a lot of severe trauma cases. We do resections of benign tumors and continuity defect. And in some cases where a lot of these defects in the old days, we would have to harvest autogenous. There was no other way to provide that scaffold and those cells. And now we can use some type of a scaffold construct, like a biomaterial, like an allograft, and combine it with something to induce the cells around the native bone with the scaffold and form bone. And so we haven't had to use autogenous bone. We haven't had to go to the hip. For many of these cases, I would say. Now, there are instances where we still do, but I would say that it has eliminated that in many, many cases. And this is true in many orthopedic practices also. We're having to go open the hip.
That's a major change.
Yes, so that's a major.
Yeah, that's a major. So the world of the biologics sounds like has been one of the major advances that you are seeing, that's allowing us to do things we just couldn't do before. And in the aesthetic zone, like you say, when every millimeter counts, having that at your disposal is huge. One of the questions I think I have that is somewhat indirectly related to that is temporization in these cases, right? Because some of these patients are going through multiple surgeries. We might have 2 or 3 soft tissue surgeries. You might have a couple of bone surgeries. And we don't want to have something obviously bouncing up and down on this tissue and putting a lot of pressure on tissue. It's different if it's a single tooth space, but if we're talking about a 4 or 5, 6 tooth space, speak a little bit to how you're sometimes managing some of these patients to give them some teeth during this process. Is this, are we resigning these patients to just being indoors for 6 months? How are some ways that you're managing that?
Wow, that's a great question. I love these questions. Looks like you've done a lot of research.
I'll tell you what, John, what we did is we created a pandemic so people could have surgery.
That's right.
That's right.
Wear a mask.
That's right. We wear a mask.
Wear a mask. Right?
So, one of the things that I think that we know we're not supposed to keep, put pressure on the bone and the soft tissue and the wound while it's healing. One of the things we don't know, that over the years that I've observed, is that, especially in the aesthetic zone, is that tissue has the ability to settle. When you make an incision anywhere, there's collagen fibers that you separate that then form, that heals. And when it heals, oftentimes these collagen fibers that are normally parallel with each other, they form into a little ball, like a ball of yarn. And so that's why when you see somebody who's had an incision anywhere, you feel this little bump. So that's that collagen ball. And then what do they tell you? Massage it, put vitamin E, do all this and that. Try to get that collagen to reorganize and flattened out. And so, and that's why one of the reasons why when you have had a plastic surgeon will never do a scar revision like 2 weeks or 2 months after you had a scar. The weight for that collagen to reorganize. The mouth is no different. When you do surgery, when you do augmentation, when you do soft tissue augmentation, bone augmentation, there's a lot of collagen that reorganizes. And in the beginning, it contracts. Now, over time, it will slowly release over time, and then it reorganizes parallel, and then it settles. The problem is that for us as dentists, is that we are trained to fill holes. When we see a hole, we want to fill it, right? We're a class 2 hole. Fill. Dentists don't like holes. Patients don't like holes. So when you leave a little hole, so when I do a surgery, I usually release, and I want that collagen reorganized. I know it's going to happen the next 4 to 6, sometimes a year. And I want to leave a hole. And but the dentist is going to say, well, how comes this black hole? Let's go ahead and suck that thing right up into the gum. That tissue will never come down. And so what we've seen is that we have to create some type of prosthesis that hides that hole. So there is a hole, but sometimes so there, you know, the Essex is a good prosthesis, and also some type of a ridge lap that overlies the ridge but does not touch it. So most of these you know, when they're delivered to me, I make sure that there's not that many holes. But if there is, I tell the patient, we don't want to touch this. But there's if it's a stay plate, they cannot chew on it. If it's a stay plate, then I reduce it completely, but nothing can touch it. This is the other area that I think is very exciting in the field of reconstruction in the aesthetic zone. Is that a lot of times we don't know right now, you know, how long it takes for this tissue and when and which patients for this tissue to come down. When we're talking about millimeters, when you're off by half a millimeter or a millimeter, it's that there's the difference between success and failure. So I think that this is an area of research, an area that in the future we can look at. But it's an exciting area. I think that we have the ability to, you know, now most people temporize for, you know, a few months. I've seen cases where I've documented where some of this tissue can take up to 2 years to settle. And so we now work with a very good lab, make a very nice provisional that the patient can wear and is acceptable. And the patient sees that and says, hey, you know, that doesn't look too bad. I can wear this for a year or a year and a half. And then we take photos. We don't tell the patients what we're waiting for, because we don't want to set up expectations. And then we continue to take photos. And most of these cases, you do see the tissue settle vertically.
And so when you talk about that from a time frame standpoint and temporization, assuming that you are able to achieve the augmentation that you desire, when are you telling a restorative dentist to start sculpting tissue? You know, knowing that we could have a year potentially for collagen to reorganize and settle. How soon after, again, assuming that bone is where you want it, soft tissue is where you want it, do you say, okay, it's clear for you to start creating your ovate pontics or whatever it might be that you're trying to accomplish, or getting into implant, you know, tissue sculpting? What does that look like?
That's a great question, John. It depends on how many surgery procedure was done on that site.
Okay.
So the desire, there's two things. One is the surgical outcome, the aesthetic outcome. What are you trying to achieve? If you've achieved symmetry, you've achieved enough architecture, you can go straight to final. The second is, you know, what how many surgical procedures. A lot of surgical procedures often cause, the more surgery you go in. So some of these complex cases, I'm going in 2 or 3 times. I've created a lot of surgical contraction. Those cases, in my experience, you have to wait a minimum of at least 6 months. A year is not uncommon. So people that go to my lecture, I always put the dates of this is when we first temporize, this is how we're following these. And sometimes these take up a year or 2 years, but patients are always impressed that, oh my goodness, I thought, you know, after 4 months, I can go to the final. But you showed the tissue settled 2 millimeters, 3 millimeters more by just waiting. And so I always wait until depending on how much surgery was done, that gives me a ballpark. If I've done a lot of surgery, I know there's a lot of contraction. Then I know I wait a little bit longer.
Certainly surgery's not over really until the prosthetics have been really completed.
That's right.
Because it's impacting the surgical site. And, you know, I think that probably has been a game changer in our practice and how prosthetics can, one, aid in surgery and destroy surgery. And I think that's one of the things that the AO has done really nicely is marrying the restorative portion with the surgical portion, because the surgeons realized, hey, we need to raise the level of our pros guys so that they can help us do this, because we don't want to, you know, do pros. We want to do surgery, but and I think the surgeons realized, hey, we can use pros to actually help us out. Otherwise, it could destroy what we've. How has that changed in your practice working with? I mean, you're talking about doing some of these things yourself, you know, and our surgeon, you know, he's like, you know, I have to do some of these things myself. You know, when we go to our surgeon's office, he's saying, Wes, can you go in here and like help me out with this because I need some
adjusting a provisional or whatever it might be.
How's it changed in working with restorative doctors?
That's a great question, Wes. I mean, very, very intuitive. You know, so yes, the AO is a great community for this. I think that we're still in this learning process. In my practice, it's I've really refined my practice to working with some of the best people in the industry. And so I have the opportunity to work with some of the best technicians, Naoki Ayashi, some of the guys that are just at the forefront of knowing, understanding how to sculpt and how to make these restorations. I would say that that's probably 80% of the game. And you know, I think that I, as a surgeon, need to know what my restorative and my pros guys do, and I need to learn all of what he knows. I don't need to do it. I just need to know as much, and he needs to learn as much of what I need to do. And so from that standpoint, I think it's been a great learning experience. It's a continuous learning experience. I've been doing this for over 20 plus years in the same practice. I'm still learning. I'm still trying to figure out, you know, at what point do I stop or when, how I can improve the results. But yeah, it's a great, this relationship. It's an ever growing relationship. And then you have to have a love for it. And then that's why most of the people here at the AO, you have to have really a passion and desire to come to these meetings and learn about what the other guy's doing.
Yeah.
So what defects, when you going back to the pink porcelain discussion, when do you look at a defect and you say, nope, this is a pink porcelain case?
So you know,
that gets to the pride.
Because obviously we can do a lot, as you're saying, we can do more than we ever could. Does that mean that every defect is treatable? I mean, or is there a point where we're down to basal bone and you're looking at this going, I don't know about this case. Maybe we should just keep everything out of the transition zone and not take risks.
Yep. So absolutely, very good point. So there's three things you have to look at. Patient factors, meaning smoker, diabetic, you know, on medications that
systemic disease.
So patient factors, take them aside. Next is site factors. Some sites are much more difficult than others. In other words, they are scarred. They've been multiply operated. They have had a lot of bad bone, bad tissue. That's another one. And then the last one is surgeon factor or the clinician factor. We know that different clinicians have different success rates. So those three things taken together. So it's not a one size fit all. We don't live in a black and white world, as I said. So this question is asked to me a lot, and I have taught CE for 20 years. And I tell them that. I say, are you up to the challenge to do this? And if you are, you know, if you do have the right patient and you have the right site, you know, is the surgeon the limitation? So I would say that pink porcelain is always the first option. It should always be the first option.
That's good.
The reason why I say that is that the majority of people do not have the resources, meaning they don't have, you know, I live in Los Angeles, in California. I have some of the best technicians that I work with at my disposal, you know, around me, and I just have some of the best prosthodontists. And I have people that are just passionate about it. They want to make that, you know, and so, and in some areas of the countries, you don't have that. And so the surgeon factor is out of the question. And then you don't have patient, you know, maybe the patient, you may have the patient and the site, but you don't have the resources to do that. Now, having said that, I would say that in my practice, we rarely use pink porcelain, no matter what the defect is. So it could be a significant, you know, defect from 6 to 11, 5 to 10, we're able to, if the fact that there are no patient factors, the site factors essentially just gives me how difficult it's going to be. And I always am very, all failures are failures of expectation. There are no success and failure. There are only expectations.
True.
I tell you, you're going to have pink porcelain and the graft is going to fail. And I made a graft that failed. You said, hey, you told me that this is the procedure. So all failures are failures of expectation. So typically, it's just how you manage the expectation. So I always tell each patient it's 2 steps forward, 1 step back. We're talking about these procedures, 2 steps forward, 1 step back. And if a patient that does not have any medical problems, I think in the air at this point right now with vertical augmentation, we're able to achieve a pretty nice aesthetic result, or at least a natural that where the patient is accepting of the aesthetic parameters that are there. I think we can achieve that in most patients, not all patients. And there is a stepped process towards doing it. It's not a one size. I see too many, I think, commercials of people thinking that there's this protocol, there's this guy, there's this guru.
Yeah.
And every 10 years, there's 5 years, 10 years, there's always a new technique, a new way to do this. I think that that's the wrong approach to all of this. When we're talking about 0.5 millimeter to 1 millimeter, 80% is just getting it there. No, 20% is getting the bone. 80% is creating that natural aesthetic. That's the difficulty. So you can have a fabulous technique, bring it down, and still use pink porcelain because you had a terrible lab or you had a terrible.
Absolutely.
I think one of the things that I'm hearing from you, and John and I love this stuff too, is the ability to talk to patients that expect not to have pink porcelain and setting the expectation. And as dentists, we have this personality type that's very technical and we're just driven to nitty gritty, 0.5 millimeter here, millimeter there, and just pare down and neglect maybe the patient side of things. And I can tell you're very good at talking to your patients. And I think one of the things that I spend more time on with my associate is how to talk to our patients about setting expectations. What are you doing right now with some of the people you're training? And how are you working with people and teaching them to work with people? Because that's a side of dentistry that we just don't really talk about.
We talk about implants are forever, right? That idea. And, we've heard this discussion, oh, it's something you present to patients. It's forever. We'll just spend this money and you'll be good to go. And the patient has this expectation, whereas in medicine, they seem to do a little bit better job, of calling things we may need a revision down the road, right? Plastic surgery is very good at that. The word revision, that's normal in medicine. And yet for us, it's like that's a failure for us. So yeah, especially with training, how are you training people to talk to patients about, especially these more complicated cases, to set those expectations? Yeah, that's a very, very, very interesting, a very good question.
How did you learn it?
Well, I learned that from years of failures, having my own failures. And when you have enough failures, you realize that, the practice of implants is that, for every failure, it takes about 3 or 4 procedures just to make even for it. So, so how I set the expectation is that my staff knows, that when we do a procedure, we tell patients that even if I place an implant in a native site, the success rate is about 94%. I said, that's pretty good. That's not 100%. That's pretty good. And when we do procedures, same thing. It's not 100%, but it's pretty good. And so the expectation is always is that these procedures we're trying to match what God gave you. We can't do that.
Right.
I'm no God.
Right.
So, and there's no procedure that can do that. But I'm going to do my best to try to match or create something that is acceptable for you. And many times we fail because medicine is not an exact science.
See, that's honesty, right? And I think patients kind of feel that honesty. And therefore, whenever you feel honesty, you extend trust.
That's right.
Trust is earned and not given.
That's right. That's right.
And so when you are honest, hey, I've had failures and this is what I expect, then they're like, you know what? This guy's not afraid to tell me.
Yeah.
what I really need to hear.
Well, and I think
Right?
that's in our world of the fast-paced, want it now approach. And I would think LA would be the forefront of that in many ways, right?
Yeah.
It's, I want this done now and I want it to be perfect. And, I think I remember Uli Grunder years ago, at this meeting just saying, I have no problem. Like I just tell patients, you're going to have nothing here for 6 months. And if you're not okay with that, I'm not your guy. And that's, that's okay. I don't have to do surgery at everyone. And so we have to maybe reframe the way we talk to patients, that it's not immediate and it's not now and it's not perfect.
That's right.
But like you say, if you have the right training, then we can set an expectation and hopefully we can actually back that up with, getting where we expect it to go. But yeah, like you said, years of failures will teach you more than anything, I suppose.
Yes, more than anything. I think implant as a commodity has been oversold and has been commercialized to the point that, like I said, although it's extremely successful, but I think that we have to be careful that we, patients go turn on the TV and they see, implants are forever, implants are successful, and we guarantee practices guarantee this, guarantee that. You have to be very careful with that, and that there's nothing in this world that's guaranteed. I always tell patients, you can buy the most expensive Ferrari or Rolls Royce, it's not going to last you forever because these are wear and tear parts, and these over time, the most expensive Rolls Royce will need to be maintenance or have to be repaired and all that. So same things with implants. There's nothing, and you have to remember also, the last point probably is that we treat patients that are very dynamic, that are ever changing. A patient today that may not smoke might smoke in 2 years. A patient that has good hygiene today might be in her 80s might not have the same hygiene, might not have the same manual dexterity. So things can go south, and so when patients ask me, what the expectations are, I always, very honest with them. I say, it really depends. It's a very constant state of flux and change. But we can do say that we will provide you a good quality of life and function for the next 10 years, and that has a very high percentage of that being achieved.
Hey, if you're listening to this and you don't want pink porcelain in your mouth, well, I know where to go.
That's right.
At least I know where to start.
Exactly.
Right? And I start with someone like yourself, sir.
Yeah. Thank you for being with us.
Yes.
And it's been a great conversation and just gives us a lot to think about as far as how to not only what's possible with augmentation, but also just more of, how do we establish those expectations? Because if we're going to do it well, it's going to take some time. It's going to take some work, and it may not be perfect, but we're getting there. We're getting closer to that.
We're getting closer. We're getting better.
Yeah. Well, thank you very much.
You guys are awesome. I really enjoyed these.
Yeah.
These are really well thought out questions.
Do it in the future.
Yeah,
absolutely.
Very nice. Thank you so much.
Thank you so much for joining us. Yeah,
appreciate it.
Dr. Lee. Well, John, here we are again. Okay, so now I pose the question. You're in a motor vehicle accident.
I knew this was coming. Well, no, I'm going to ask you the question this time. All right, turn this around. So, I mean, how do we handle this now? You lose 5 through 10, in a trauma, and how do you even have this discussion of what would you choose to do? And I think what I'm getting from this, and I want to hear your thoughts on this, is that it's possible, absolutely possible, to accomplish some amazing things, but it takes a lot of time, potentially. It takes a lot of work. The temporization is not easy. Special temporaries. You may be in a flipper with some kind of a weird tooth-borne device. You may not be able to wear anything, right? Right. I mean, and that's just where I feel like, again, I mentioned this, but I remember Uli Grunder years ago just saying this, and it was like for my American brain, quote unquote, to think that I would say to a patient, it'll be 1.5 years. Right. It'll be probably 6 to 8 surgeries. Right. And you will for some time be without teeth. And I remember him just saying, that's just not a problem for us over here. This is what we do. And we just tell the patient that's what to expect. What I take from this is that we've came a long way. There's been some things that have come into the market, per se, biologics that have changed us. I mean, you heard him talk about eliminating the need for iliac crest grafting. Well, that's the most painful thing, for instance, right? That's huge. It's huge. And I think, too, is understanding your limitations as a clinician, surgeon, and then understanding the limitations of the patient. We still don't know how to treat real sick people. And we don't know what, and that's you have to realize the medical factors. Am I starting with a sick person? And then on top of that, like maybe only have a limited skill set, because he can't pare down what
actually he's going to use, because it's a gray area, right?
Exactly.
So,
And I like the fact that there's no magic technique. There's no magic cure. It's not one material that we use, because that pigeonholes us in a world where this is medicine. It's the practice of, it's not just going to be a specific technique every single time. And that's something that we need to hear, because I think we all want to know, what works today. And that's just not always the way that this world works. So,
well, John, we've got a few minutes here, and getting ready to bring on our next guest.
Yes.
And I tell you what is, I think about the AO like I think is that where else are we having these conversations?
Well,
right. So how can people ask questions? Because I want some questions for our speakers.
Yeah. So if you're listening to this and you're thinking, how do I get in on this conversation? Well, there is a way to do that. And that is by sending us your questions to hashtag AODentalGuys22. You can actually get your questions to potentially some of the speakers we're interviewing. You can actually ask them what you want to know, because we know we're bringing you some of the top minds in implant dentistry in the world today, and this is what gives you access to them. So if you're not already on the social media side of things, now's the time to jump on there and get those questions out, so that we can ask those to our speakers, because not only today, but in the next couple of days, we're going to have plenty more to talk to. So check out the schedule for the coming days to see who's coming up, so you can get questions to us.
You know what tonight is? The Young Clinicians reception, right?
Coming right up.
Right after this, we're going to head over there, and we're going to hang out with some young clinicians. Are you still young?
I'm going to say tonight, I feel young.
Tonight, I feel young.
Tonight, yeah. But I mean, I'm going to, we're becoming those guys now that we're not.
Are we?
Are we not? I don't know if we're in that group anymore.
Well, the other day, John, I was pulling up and I was working on a lecture to present, and I looked at this case, and in the lecture, it was a 5-year follow-up, and I'd just seen the patient, and it was a 15-year follow-up on a molar implant that I placed. And I was like, what?
Yeah.
Like 15 years I've been doing some
all
of this.
All of a sudden, you're not a young clinician.
You're not a young clinician.
But, that's just part of it. And again, as Dr. Lee was just saying, I mean, this is part of the great side of experience and failures, right? You get to see your good stuff and your failures. You learn a lot from that.
Well, it's time to bring on our next guest.
Yes.
And I'm super excited to have Dr. Norton and Dr. Testori to talk a lot about really what has been on our minds since I talked to, and I'll tell my little story about insertional torque value. And I was placing an implant that Dr. Norton knows so well back over 10 years ago. And I was at Lyndon Cooper, a very special event that company put on at UNC. And I went up to him afterwards and I said, so I've read a lot of your studies on bone and how it works. And I said, I trust the implant, and I trust the technology behind it. But what I can't get past my mechanical mind, my dad's an engineer, is the fact that you say that a low insertional torque value here, as long as you can't, he said this, he's like, Wes, he said, as long as you can't spin it in the bone, in your hand, then trust it. And I was like, and you're second staging? So here we are 10 years ago where I'm burying everything. Right? I mean, let's put it all to sleep, right? And I go to, if it doesn't spin, put a healing abutment on it, John.
Right.
And I remember telling you this, and you said you're a cowboy.
Right.
I said, but doc, what?
I did call you a cowboy.
The research. You called me a cowboy.
I did.
Right?
I did. And because it challenged my thought process. So here we have, Dr. Norton, Dr. Testori, both widely published in the areas of both insertional torque value. We've obviously talked a lot about that through textbooks, through articles, and also ISQ and resonance frequency analysis. These are both areas that you guys are both quite familiar with. And we would just love to have the discussion of, how much do these things matter? How much does torque matter? And how much should we rely upon it? How much does ISQ matter? And how much should we rely upon it? How tight is too tight? How loose is too loose? These are topics that both of you are, of course, very well versed in. We'll start with you, Dr. Norton. Talk a little bit about today, your thoughts on these issues.
So thank you for inviting me here. It's great to join you guys. And let me start by saying I was being very kind to you, because I told you, according to you at least, that we stop at spinners. We absolutely don't stop at spinners. Spinners are our friends. We put a healing abutment on them.
This is what I was waiting for.
It's absolutely no issue.
Yes.
And in fact, the way you introduce that topic, just it's like reeling in the bait. I mean, you know, you said your dad was an engineer. Is that what you said?
That's right.
Yeah, well, I got news for you. We're not carpenters and we're not engineers. We're biologists.
Yes.
We are surgeons treating a living vital tissue. We're not working on bone, on wood, I should say. And there is a fundamental difference. I mean, let's keep the metaphor going. Okay, so you have a picture or a painting. Human beings are actually really good. You pick up in terms of visualizing the concept of primary stability. How do I mean? So you pick up a painting or a picture that you want to hang on your wall. You immediately get an impression in your mind of how heavy that painting is. And that impression in of itself gives you an understanding of how big the screw or the nail or whatever you're hanging it up with, right? How big it should be, how deep it should be. And when you drill into the wall, is it brick? Is it breeze block? Is it drywall? Your brain immediately calculates the bone density of that wall, if you'll run with it.
Oh, yeah.
Right?
Yeah.
And somehow or other, you make a qualitative assessment of how big the screw should be, how deep the screw should go into that wall in order to hang that picture. Because, sure, you don't want to come down the next morning and find the picture on the floor shattered into pieces, right? The problem is that substrate is an inanimate substrate. It has no potential to change the way in which it interfaces with the screw. So you go back 10 years later, you hate the picture, right? You hate the frigging picture. You want to take it off, but now you've got a screw in the wall. So you want to take the screw out and patch it up or whatever you want to do. Thing is, you can take the screw out. There's been no change in the relationship between the screw and the wall, the screw and the substrate. That is not a dental implant, and bone is not an inanimate substrate. So now if we bring it into the biological realm, you take that same innate understanding, and it's an amazing innate understanding, but you apply that to a living vital tissue like bone. And what you actually do is you damage that bone, okay? The desire for getting this massive insertion torque so that it's really tight, so that you can go home and feel good about the fact that your immediate load provisional or whatever isn't going to fall out that night. That's fine at that level. But what you don't see is what's happening at the cellular level. The damage you've done to that bone through super compression, right? The potential start of a pressure necrosis curve, which may not translate all the way through to actual pressure necrosis, but the literature is abundant with evidence that you damage that bone. Now, I'm not saying, and I have never said, that translates to higher failure of implants, because it probably doesn't. But what it absolutely does is translate to a poorer quality of osseointegration that takes longer to achieve because of the damage you've applied to the bone. Well, I don't want that. I want quicker osseointegration, and I want a better quality of osseointegration. And the way you do that is to respect the bone, to get enough primary stability, however we measure that, which we're going to talk about this evening, to get enough primary stability to do the job, but without insulting the bone. And that's always been my position. And it's still my position.
Yeah, Dr. Testori, respond to that. How do you feel about that and the pressure necrosis curve? And this, is it just a matter of putting it in to feel good about yourself at the end of that procedure?
No, I think he made the point that the last word, you should not do any damage to the bone first. But pressure necrosis, and we wrote a white paper with Alan Meltzer many years ago, myth or reality. We think that it's a myth. So to be very practical, First of all, should I do an immediate load case or should I do a delayed case? If I should do an immediate case, single tooth restoration, I got to have that implant that is stable. And the implant should not scream in the bone, but the implant should have 40 to 50 Newton centimeters of primary stability. And we rely upon insertion torque, incremental insertion torque. So the curves should be incremental. We don't like to have a flat curve and all of a sudden a peak torque. To be very practical, we never teach to under prepare the cortical, because if you under prepare the cortical, the implant cannot go flush with the bone. So it's a matter. And on top of that, it's a post-extraction case, is not a post-extraction case. And then we learn over the year how to respect the bone, not doing any damage mainly to the cortical, but the implant should be stable in medullary bone. That's our position. And on top of that, we speak about torque, but which device you have, which drilling machine, because clinician take a lot of attention on the implant, the hardware, but not on the drilling machine. You got to have a reliable drilling machine that gives you the readings, because otherwise, and then another big issue opens. Is the handpiece well lubricated? It's old, it's not old, which kind of burrs are you using, are you doing guided? So there are multiple factors that can mislead the clinician in the torque value readings. And on top of that, you should always give a limit to the doctors in order to understand that which is the average torque that you need to have. For single tooth application, in the range of 40 to 50, even if there are papers in the literature, if you take the Kayat kind paper, is showing you with the Nobel implants, with the real torque device that can measure the torque, implants that goes in 172 Newtons. But then you should ask yourself, ask the company, the implant system that you use, at which torque you have a deformation of internal X or the external X, because otherwise that implant will not be used for a single tooth application. And then you should really understand the biology behind that. In the next issue of Geomy, we published 39 very atrophic mandibles. That means 6-7 millimeters. White bone like this desk, so very dense, 20 Newtons, and immediate loading, because in very dense bone, you cannot have micro movement, and we did immediate loading. And the referees gave us hard times, and they said, how comes that you have clinical success, but you have only 20 Newtons and you immediately load? It's too low. No, you don't know biology, my dear referee, because the bone is white like this. We are in the interforaminal mandible. So you have to control the micro movement, and the insertion torque and the primary stability in very dense bone is not that important. In dense bone can be detrimental, not to the bone, but fracturing the mandible. And we present in one case in which we, at the university, the guy was placing the implant, not following the protocol, and screwing the implant because of immediate loading, not following my guidelines, and we have an initial fracture of the mandible by torquing the implant. So primary stability and bone quality, they got to be in some way very well known by clinicians. And on top of that, the shape, the macro geometry of the implant. every kind of implant has a kind of specific indication. It depends on we do a lot of post-extraction cases, and that in order to have in the upper jaw a better primary stability, the macro geometry plays a role. Because if you don't have enough bone in the apex of the tooth, can I still do immediate loading? Yes, you can, but you got to have the right shape. So I perfectly agree that biology is very important, but on top of that, we should take into consideration which kind of drilling machine, the armamentarium that we are using. We get to know that. And on top of that, all the other factors.
The market has definitely followed what Dr. Testori is saying, is that, we're going to change the design of our implant to make us maybe feel better or follow along the lines of these V threads in that medullary bone, these compressive threads in that upper middle third, and then less pressure on the cortex because, we know what happens there. And then also I think about resonance frequency analysis and the fact that research has really shown that it is the only way to truly track bone to implant contact, which in a smooth or maybe an older school design implant where we had lower insertional torque values, we had maybe more BIC, right? And we achieved similar outcomes and maybe better outcomes than high insertional torque values.
Speak to that, Dr. Norton, because I know you've published several articles. I remember going back years ago to an editorial in Jomi where you talked about viable constraint. And that got us thinking as you actually had an equation. It was a beautiful thing to see an equation. We like equations here at the Academy.
We can quantify something.
Yes, but that got us thinking a lot about how much we should push this idea of torque. But as a counterpoint to that, or maybe to add to that, where does the ISQ fall in a way of comparing these two approaches? Because it seems that may be a way to differentiate.
Yeah. So, I mean, first of all, let me say I have a huge respect for my opposition camp. Okay.
We knew that.
And I think it's important for your listeners to understand that this is educated debate. This isn't
this is true science,
this
though,
is
right?
true science, and it's not a duel.
That's right.
Okay. It's a search for the truth. The first thing I want to say is it's very interesting to me. I am a clinician first and foremost. I'm not a bone biologist. I'd like to think a part of being a clinician is being a biologist, but I'm a clinician first and foremost. And yet the interesting thing is actually, if you distill the literature in terms of all of the articles written about particularly the influence of high insertion torque on what you affectionately call BIC, which for those who don't know stands for bone implant contact. And those who are proponents of high torque, like Alan Meltzer particularly, what you see is that it's actually the bone biologists, the pure bone biologists, the guys who are in the fundamentals like John Brunsky and Jill Helms and Lyndon Cooper. These are the sort of people who are looking at the way a bone cell reacts, at the way things happen at the biological level. Whereas the people who are publishing, like Philippe Kayat, who I know extremely well, and Alan Meltzer, and others who are proponents of high insertion torque, are pure clinicians, right? And I think that goes to tell you something.
Yes.
Okay. What I've tried to do from my editorial, which you so kindly brought up, 2013, and I was very grateful to Steve Eckert for allowing me to publish that, because that really was the firing gun for this debate. What I was trying to do was to try and see if we could start to achieve a middle ground between these two camps. And I think bone to implant contact, and I refer to that as just quality of osseointegration. There is a huge difference between talking about quality of osseointegration and implant success. An implant can be very successful in terms of does it drop out or does it stay in, and the quality of the bone implant contact. Actually, an Italian colleague of yours, Paolo Trisi, published a fascinating study, one of the first studies in the sheep model, you may remember, looking at high versus low insertion torque. And what was interesting in that study, and he saw his own results in a very different way to the way I saw them, but in his high insertion torque studies, he got a lot of microfractures of the bone. And in the low insertion torque study, he actually had a gap between the bone and the implant surface. And so the way he presented that was basically to say that in the high insertion torque group, they had a high bone to implant contact. And in the low insertion torque group, they had virtually zero bone to implant contact, but only because they'd over prepared the osteotomy. But when you looked at the 6 week or 4 or 6 week follow-up, I don't remember what it was, there was a mass resorptive process around the high insertion torque implants, and there was actually a de novo bone deposition filling in the gap in the low insertion torque group. So this is the way that biology responds to pressure. Now, Tiziano, you said yourself, you know, in that marble bone, that quality 1 bone, you only had 20 Newton centimeters. Yeah. And it was interesting to hear what you said about the editor's reaction. One of the articles that and I'm going to embarrass myself now because I'm getting senior in age and I'm starting to forget things. It's an article that I've referenced 1,000,000 times. And for the life of me right now, I can't remember the name of the author. But in this 2006, I think it was, article, the authors were doing atrophic edentulous mandible immediate load cases. And the most amazing statement in the discussion section of that article, and I'll have to send you the reference because it's not coming to me, but if it does, I'll tell you. They actually identify or point out that they had a minimum target insertion torque of, I forget what that was as well, 40 Newton centimeters, let's say. And something like 75% of all the implants failed to achieve the requisite insertion torque. Most of them, something like 60% of them, were under 25 Newton centimeters, but they got a 98% success rate. And in the discussion section, they themselves questioned how was it possible that they got that degree of success with such an inadequate insertion torque. How is it possible that Tiziano has done what he's done in this marble bone at 20 Newton centimeters? So that brings us very nicely into the discussion on ISQ. Because if you take the marble bone, that quality 1 dense bone scenario, let us imagine, if you will, that you prepare the osteotomy to full diameter. You then use a bone tap, let us say, right?
And cylinder implants.
And cylindrical implants. So now you have an implant that has pretty much no compressive friction, rotational friction or compressive friction against the osteotomy, because the osteotomy is now basically not only the same diameter, but it's been pre-threaded.
It's machined.
It's machined.
Yes.
Right. So the question I have for you is, how can that have any primary stability? Well, the answer is because the biggest misnomer in implant dentistry is that primary stability is measured by rotational friction. That makes no sense.
Right.
Primary stability is measured by axial stiffness.
Here we go.
And if you have a perfect fit between an implant and an osteotomy in dense bone, where there is basically no compressive friction at all, you still have a very high axial stiffness. So now you have the perfect combination of high axial stiffness, zero compression on the bone, so you haven't destroyed the bone cells. They're happy. Happy days. They're going to produce new bone, and they're going to osseointegrate faster with a higher BIC, as you call it, in a shorter time. And that's what we look to achieve.
So
I think
so in saying that, where do we see the problem with that line of reasoning? Is it, you mentioned that you feel that the pressure necrosis is a myth, or that you feel that it is not as important?
It's a myth within the boundaries. We get to give numbers to the clinician, because high insertion torque, we should give them guidelines, and they should stay within the boundaries of those. I mean, high insertion torque, if you speak about 70, 80, it doesn't mean anything, because you don't need that. It can be detrimental to the geometry, inner geometry of the implant, can be detrimental to the bone. So the guidelines for the guys that are in the field working on patient every day, do not under prepare the cortical layer. You got to have congruency with the cortical layer. You got to pick up the right implant shape according to the bone. In our data set of mandibles, 39 mandibles, is not a big data set, but we have almost 200 implants. Very old patient, cylindrical implants, and the thread pitch 0.6, pre-tapping, no important primary stability to 20 newtons. And one point that I already said, it's very important for us to understand that we got to have a reliable tool. At the beginning, to be very frank, I was involved with the hostel, with the resonance frequency analysis. Then over the years, we forgot to use that. It faded away, because I am surgeon and I'm placing the implants, and I do not see the need now for resonance frequency, because I have 41 years of practice. My first implant was placed in 86. But I think for the less experienced doctors, I think resonance frequencies analysis is very important to understand. And then for secondary stability, I do think it's the only way we have to monitor the implant. So from my perspective, is very important resonance analysis frequency. If you have referrals, to check for litigation, and even to prove that you have osseointegration, to monitor the implants down the road. And maybe for guys that they have a lot of practice, a lot of experience, might not be so relevant at implant placement. This is my idea, but it's something that no doubt there's a scientific base behind that, a lot of literature, and every young doctor should study that and get involved with resonance frequency.
Well,
so
yeah, you've got it.
I got to come back.
I saw
on
you
that.
shaking your head there. We've got just a few minutes here.
Okay. So first of all, the first thing to say is people don't have to believe in pressure necrosis or not believe it. Go onto Google, type in dental implant pressure necrosis, look at the stack of images that come up. They're all aggressive thread implants. All of the pressure necrosis is not in the cortex, it's in the cancellous compartment. This is real. I see it regularly from patients that are referred to the practice. What really gets me angry is that the accusation is that these implants have failed from peri-implantitis. This is not peri-implantitis. This is unacceptable carpentry masquerading as surgery. Set that aside for a second. Let's just talk about ISQ. I have 32 years of experience placing implants. Like Tiziano, I've placed thousands of implants. I think I understand and know what represents good implant placement. I have lots of patients that I still see who I treated 20, 25, coming up 30 years ago. So I understand it. So why the hell would I bother with ISQ?
Right.
I'll tell you why. And this is the mistake, I think. And I met with the guys today from Ostel, and you could level it at the whole, if you like, marketing of that concept. ISQ should not be sold as anything more than a 2-measure instrument. Torque is a 1-measure instrument. You can't go back and remeasure the torque and get any appreciation for any change in the interaction between the bone and the implant. I don't care how experienced I am. I get, you know, my personal success rate in practice is audited every single year, year in, year out, has been for the last 30 years. My success rate is somewhere in the region of 98 to 99%. Okay, so I have every single year 1 to 2% failure rate. So you could say, well, why bother with ISQ for that? Answer, because I want to eradicate the 1 to 2%, because I don't want any patient to be that 1 to 2%, because for that patient, it's 100%. Well, I restore a lot of the implants I place. And one of the beautiful things about ISQ, whether you believe it predicts failure or not, it's irrelevant. It's a red herring. What predicts, and it's not a prediction, it's an actual, is when you see an implant placement, you had a primary stability as measured by ISQ of, say, 78. 3 months later, you come to take the healing abutment off and take the impression for definitive restoration, and suddenly the ISQ is 65.
Oh my.
You got to ask yourself a question,
Right.
right? You got to take an X-ray. You maybe take a scan, because maybe you don't even see it on a 2-dimensional X-ray. But you have to ask yourself questions, and you have to delay the restoration of that implant. That's why I do ISQ, because nothing else in the industry gives us the opportunity of comparative assessment of the bone implant interface, and nothing else is currently available that gives us the opportunity to at least try to eradicate that 1 to 2% failure. Torque can't do that for you.
Right. Now, I will say, just to kind of come back to the, oh yeah, go ahead. Go ahead. Of
One
course.
thing, I am a medical doctor, and it's important not to rely only on one factor in medicine. You have to rely on multiple factors. And we learn over the years how to fool the instrument. If you have an implant, you have a cortical layer, no bone there, very little density of that bone, and you hammer the implant and you take an ISQ, you can have very high readings, but that implant is locked only in this cortical layer.
Yeah, but that's only one reading, Tiziano. You have to retake that reading some months later, and then you're comparing like with like.
Yes, I'm telling you, at first stage surgery. I'm not saying that it's useless, but I'm saying that you got to have multiple factors
100% agree.
to analyze, and then you get to know biology, and you got to understand how the tool works, because
100%.
otherwise, if the young guys only at least one readings, and on top of that, if you are in the, let's say, poor quality bone, and you got to screw the post on top of you can lose a little bit of primary stability. I've seen that they can move. So there are multiple factors to analyze.
Yeah. There's no question. If you only use ISQ as a one reading instrument, it's no more valuable than using torque as a one instrument reading.
Well,
it's useless.
And how important, conversely, then I will say, you mentioned, spinners are our friends, right? So if you're going for an immediate loading situation, right? What are you shooting for? Is insertional, is ITV something that you say, well, I would like to have a certain number? Does it matter more when we're immediately loading than if we are planning on doing a two-stage situation.
So in my 2017 article, where I use ISQ to look at could we identify a threshold of insertion torque where axial stiffness actually becomes more predictable?
Mm-hmm.
I've always in my lectures said 25 Newton centimeters, 20 to 25 Newton centimeters is the minimum threshold. I probably still stick by that, but actually I disproved that, because in my 2017 article, what I actually showed is that the variability of ISQ values was very wide for all implants placed under 10 Newton centimeters. But when you got above 10 Newton centimeters, the variability in ISQ was almost nothing. I mean, the distribution around the mean was minuscule. And so actually what I demonstrated in that study is that anything over 10 Newton centimeters actually has a predictable stiffness. So if you have an insertion torque above 10 Newton centimeters, which let's face it, most people do, okay, whatever your ISQ value is, it's probably pretty accurate. You could take it 100 times, it would be that value. So if that value is under 65, you have an unstable implant. You should not immediately load it. But if you have a value of 68, 70, 75, and let's be clear, you can have an ISQ value of 75 with an implant that has an insertion torque of 10 Newton centimeters, I have no compunction loading that implant immediately.
Well, there you have it. We're going to be 40 to 50, right?
Yeah.
And we're going to have an insertion torque of 10, but we're going to have to read an ISQ of at least 65 plus, right? And so I hate to even shut this down because here's the thing is that for years I've read these articles.
Oh yeah.
I'm teaching this. My first slide in the recent lecture that I taught, you saw it.
Yeah.
It has a mechanic on one side, split right down the PowerPoint slide, and it has a biologist on the other side. And it has this little circle spinning with arrows, right? And it's teaching dentists to not just be a mechanic, to be my dad's engineer, but to be a biologist, to be a doctor, like you said. And one of the things about doctors is we do like to have two things that confirm a diagnosis, right? And I know that with recent things and even my own family, learning about diagnosis and diseases and how we do things. And I think as we become better doctors, we'll become better mechanics. And for biology that's dynamic and not static. I really want to thank Dr. Norton, Dr. Testori for coming on. They both are friends. And this is what we wanted, John, this is what science is all about. And you know what? This is what the AO is all about. The AO is all about bringing you next level content that you can really come to a place where you can learn what great clinicians and researchers are doing. And so,
and join in the debate, because it is a spirited debate. And again, it's a search for truth, as you said. It's that's
science.
That's what science is all about.
So if you're listening to this right now, listen, I need you to give us a like. I need you to give us a share. I need you to tag us. I need you to send this across your ways. If you have questions for the Dental Guys and the Academy of Osseointegration, we're using the hashtag AODentalGuys22 this week. Head us up on Twitter right there, either on the Dental Guys Twitter page or the Academy's Twitter page. We're excited to bring you next level content as we start this again tomorrow, John, with more live streaming. So make sure you hit the notification bell on all those outlets. And so for Dr. Testori, Dr. Norton, for John, I'm Wes, and this has been another broadcast of the Dental Guys.